Well, I'll just go right ahead then, just to keep things on time. Happy Friday, everybody. I'm filling in for Sarah Bradley, who could not make it today and doing the introductions for today's rounds, but we're very, very excited to host Dr. Ganguli, who's an associate professor of medicine, a health services researcher, and a practicing primary care physician at Harvard Medical School and the Brigham and Women's Hospital. Her research focuses on primary care payment, delivery, and policy, the use of consequences and cascades of low-value care, innovations and trade-offs in ambulatory care for older adults, and gender equity. Dr. Ganguli serves as the associate editor for JAMA Internal Medicine and is a member of the National Academies of Sciences, Engineering, and Medicine Standing Committee on Primary Care. She's also a former journalist who has written about science and healthcare for the Boston Globe and the Washington Post, among other publications. She received all of her degrees, or many of them, at Harvard and has completed internal medicine, primary care residency, and health policy and management fellowships at Mass Gen Hospital. So obviously a very compelling title. Love that. And so we're very happy to have you here today and turn it over to you, Ishani.
Thank you so much, Dr. Wolf. It's really a pleasure to be here, even if virtually. And this is a topic that is more recent in my area of interest, and I'm delighted to share this with you and to get feedback. So I'll be speaking during this hour informed by a number of different hats that I've worn, and Dr. Wolf alluded to most of them. I'm going to be thinking about this topic or sharing this topic with you as a health services researcher, in addition to as a primary care doctor. I was also a fellow during fellowship. I spent 2 years working in an operational role for a health system, and I'll share some of those perspectives as well as my my perspectives as a former journalist. So I'll go ahead and jump in. Oh. All right, so a number of disclosures to mention, including grants from the NIA and other sources, as well as consulting fees from F Prime. What we'll cover today is this idea, is a couple of things. We're going to walk through the idea that getting to the doctor's office or hospital is not a trivial task. And yet we ask patients, in particular older adults, to come in quite often. And I'll ask you to think about the idea that given trade-offs of contact days, healthcare contact days, when people are coming into the office or hospital setting, how can we optimize how we use these days as clinicians and as health systems? So first, this idea about getting to the doctor's office. So there's been a number of studies in the general population using time use data, finding that people spend about 2 hours per visit. So in other words, you're coming in for a doctor's visit, you only spend about 20 minutes with the doctor, but you're spending 2 hours in total with transportation, wait times, et cetera. That also comes at a $43 opportunity cost on average. And we also have found others have found disparities by race and education in the time spent and the opportunity cost spent. And this is work done by Kristen Ray and others at UBMC. This is particularly important for older adults. So work by Catherine Ornstein has shown that the older adults who are homebound in the community setting are about 6 to 8%, including a study that came out just recently in the Medicare Advantage population. But these challenges likely extend beyond that. So this chart here shows the cumulative incidence of the homebound population up to 13% in this longitudinal sample that she looked at. But the challenges likely extend beyond that to the majority of older adults where there is some friction or challenge to getting to the office, and that extends as well to their care partners. So to try to get at this question, we did a study to understand which older adults face the barrier of trouble getting to the doctor's office and how they access visits. This was a cross-sectional analysis of nationally representative data from the Medicare Current Beneficiary Survey. We used 2019 data, the last year before the pandemic. And we focused on older adults, so 65 and older, who are community dwelling and continuously enrolled in Medicare, including MA and traditional Medicare. And we really took advantage of a new question that had come out that year. Specifically, the question, because of a health or physical problem, have you had trouble getting places like the doctor's office, a supermarket, or a friend's house? We looked at sociodemographic and health factors associated with this trouble and used multivariable logistic regression to analyze them. So you can see some examples here. We have a number of sociodemographic variables as well as self-rated health and presence of a number of chronic conditions. We then, among those reporting trouble, estimated the presence of functional impairment, defined as difficulty with one or more of 6 activities of daily living, as well as report of home-based usual care. And then among respondents who reported a usual place of care outside the home, we compared visit access approaches using chi-square tests. So first, we found high level that about 17% of Medicare beneficiaries, representing 48 million beneficiaries across the country, reported trouble getting places like the doctor's office. Of these 48 million, 2/3 had functional impairment, and only 1% reported home as their usual place of care. When we looked at sociodemographic variables associated with trouble, we found that older age was associated. So folks who were 85 or older had 3 times the odds of reporting this trouble compared to those who were 65 to 69. Female sex was associated with reporting this trouble, as was lower income, more modestly. We found no significant difference in the type of Medicare one had. And we found, although there was a trend towards Medicare Advantage having less, which is consistent with what we know about selection in that group. And then we found that those with Medicaid eligibility also had higher odds of reporting trouble. We did not see an association with other factors, however, that you see here, like race, education, or living alone. Then we looked at health factors, and the biggest predictor here was fair or poor self-rated health. And I should mention this models included both sets of factors, but I'm presenting them separately. So fair or poor self-rated health was strongly predictive of reporting trouble, as was some chronic conditions, but not others, including heart disease and stroke, rheumatoid arthritis, mental illness, and dementia. Dementia being the strongest predictor in this set. I'll also point out that each additional condition, so for every condition that contributed to one's multimorbidity, there was an increased odds of reporting trouble by 1.41. Then we asked questions about how these patients got to the doctor's office. And here you can see in orange, these are adults who report trouble, and gray are the ones who do not. So for those who report trouble, less than half drive themselves, and it's quite common for them to report that they're driven to the doctor. This is their usual source of care. About 41% were driven, 2% used the ambulance, 2% used taxi, and 4% used public transportation, in contrast to adults who don't report the trouble, who are largely driving themselves. And then we asked how and how often they go to the doctor's office, or we looked at that question. And we don't see a marked difference in the time taken to the doctor's office, although this is a fairly crude measurement. So adults with trouble, about 22% reported it takes at least 30 minutes to get to the doctor's office versus 18% in the no trouble group. Adults with trouble were much more likely to have someone accompany them, which is consistent with what you just saw. So 54% versus 26%. And then I'm also really struck by this final finding about how often they missed appointments. You can sort of see a difference between the two groups in patients missing appointments, but what I'd highlight is the never. So despite these difficulty getting to the doctor's office, 86% of people who report with that trouble still never miss an appointment. And I think that's a really important takeaway, sort of speaking to how patients often really put a lot of stock and try their best to come to these appointments despite these challenges. So putting this all together, we found that nearly 1 in 5 Medicare beneficiaries reported trouble getting places like the doctor's office. We also find that barriers are not restricted to physical limitations, although that's a part of it. And in case in point, 1 in 3 had no functional impairment. So these are different constructs that we're looking at here. We saw a strong association with certain risk factors, including dementia and mental illness. And we also see a weaker association with lower income. And this is consistent with work finding that healthcare facilities are more likely to be leaving low-income areas. This is work by Jennifer Sui and others. So the work also really points out the burden of office visits, right? So there's the effort of transportation, there's the time spent, there's the opportunity cost for patients and care partners. So this leads us to the next point, which is that we ask older adults to come in quite often. And we all know this empirically or anecdotally as, I should say anecdotally, as clinicians, as patients, as caregivers, as daughters, sons, et cetera. And really wanted to sort of capture and put numbers to this idea. And so we turned to a metric called healthcare contact days. So for some background, this is a measure that was introduced briefly in a 2016 Dartmouth Atlas report by Ellen Mira and Julie Bynum and others, and hadn't really been looked at much since, other than one other study where it was one of many outcomes for a narrow group. This idea of contact days expands on home days or healthy days at home that you may all be familiar with, in that it includes ambulatory care. So home days is just days not spent in an institutional setting. Contact days refers to any day you go in for anything from a lab test to being hospitalized and in between. And it also parallels a recent idea within the oncology literature of time toxicity, which refers to days spent getting care for a cancer treatment in the context of folks who are have terminal or advanced cancers. And that's been studied in trial settings largely. So we wanted to look at this and sort of think about how to use this as a claims-based measure and more broadly. So the aim of this study was to characterize the magnitude, content, patterns, and drivers of healthcare contact days among older adults in a nationally representative Medicare sample, the same sample I mentioned earlier. So we used 2019 MCBS data linked to Medicare fee-for-service claims. We focused for this on fee-for-service beneficiaries because we had reliable claims data linked for those patients. And we focus on those without end-stage renal disease because prospective payments for that population preclude our ability to measure contact days. We looked at those who were continuously enrolled for a year or until death and were alive at least a month in the sample period. This is a depiction of the measure. So you can see that it includes institutional days spent in the inpatient, ED, SNF, or hospice, as well as ambulatory days spent in office visits, procedures, treatments, imaging, or tests. And we looked at a number of covariates or variables that may be associated with these contact days, including sociodemographic, clinical, functional, and care-seeking behaviors. For example, I worry about my health more than other people my age. I go to the doctor as soon as I start to feel bad, or I will do just about anything to avoid going to the doctor. And to construct this measure, so we essentially recreated what was described in that report and updated the measure using a number of more recent advances, including BTOS codes. And we merged a number of different files in Medicare. There's a lot more detail in the appendix, but happy to discuss if of interest. So the analyses involved weighted cross-sectional descriptive analyses of the contact day magnitude, composition, and variation. We looked at care patterns, and we looked at contact days composition within patient subgroups. We also identified patient factors associated with contact days using multivariable Poisson regression with an offset for days alive and HRR random effects to account for practice variation by HRR. Here are the main results. So we found that across about 30 million older adults in fee-for-service Medicare, the average number of days spent getting healthcare across a year outside the home was 21 contact days. There was wide variation in this. So about 11% of these older adults had 50 or more contact days per year. And you can see in this image, I know it's quite small, but you can see that these are violin plots essentially. For total contact days right here, you can see that the tip of this figure shows 250 contact days. So there's some folks who are as high as that, and that there's a lot of variation, especially in the ambulatory contact days, and certain other contact days contribute more than others. We found that most contact days were ambulatory, as I mentioned, and on average, patients spend 6 contact days in specialist visits, about 4 in PCP visits, about 5 in getting tests, 3 getting imaging, 3 getting procedures, and 6 getting treatments. So what are these actual services? This is was buried in the appendix, but I think is super interesting. So when you look at the sort of rank the different subtypes of each type of contact day, you can see some interesting patterns. For example, specialty care visit days, ophthalmology is taking up the most of this time. So 12% of specialist visit contact days are ophthalmology, followed by 9% in cardiology. For test days, labs, general labs are by far the most prevalent. About 73% of these tests are labs, followed by cardiology tests. Imaging days, X-rays represent 53% of these days. Procedures, it's the skin procedures that are really taking up older adults' time. So 51% of procedure days are for skin procedures. And then finally, for treatment days, about 44% are for PT, OT, or speech therapy, followed by injections and infusions. So we also looked at these contact day patterns, and many ambulatory service days, importantly, were not on the same day as a visit. And that included about 49% of test days that were not on the same day as a visit, 50% of imaging, 84% of treatment, and 68% of procedures. And this is important to the extent that there are often opportunities to do tests or other services on the same day as a visit to consolidate care. We also found that 3.2% of all visit days involved more than one visit, meaning most of these visit days were just one visit. We also looked at contact days by days of the week. So we looked at the distribution for institutional care first, and not surprisingly, that's really on the top here. I'm going to circle it with my mouse. You can see that there's no significant difference and no difference in the percentages here by day of week in institutional care, which is exactly what we'd expect. But then when you look at ambulatory care, you see some really interesting patterns. First, you can see that there is a large drop and almost no ambulatory care offered on weekends, which is not surprising. You see anywhere from 0 to 1% across the week that are offered on the weekends. But second, we see that even among weekdays, there is a significant variation or differences such that Fridays are significantly less likely to have ambulatory care than Mondays through Thursdays. This is especially true for specialist visits, where you see this large drop to 13% of all across the week. 13% of specialist visits occur on Fridays compared to 23% on Tuesdays. That's the big day. And similarly is the case for tests, imaging, procedures, and treatments, where they're really concentrated on earlier in the week. We also looked at factors associated with ambulatory contact days, and we focused there because A, that a lot less work has been done in this area, and B, because there's a lot more variation in ambulatory contact days. First, we find something really interesting, which is that age, when accounting for other factors, age is inversely associated with ambulatory contact days. In other words, the older you are, the fewer contact days you have. And we can talk about maybe why that might be. Female adults had more contact days. Patients who were Asian or Black had fewer relative to white patients, and Hispanic also fewer relative to non-Hispanic white. We found some subtle differences by region in which you live. So urban residents had the most contact days relative to micropolitan or rural residents. And then there was no link between self-reported health and contact days or functional impairment, but chronic conditions really, as derived from claims-based data, really drove these contact days. And so for every additional chronic condition that you have, you experience 11% more contact days, which is really striking. We also see some really interesting and really sort of rational patterns with the care-seeking behaviors that we captured. So patients who worry about their health more than average and see the doctor as soon as they can have more contact days in the ambulatory setting. Patients who avoid the doctor have fewer. It makes a lot of sense. And it's even after controlling for other markers of patient need. So putting this all together, older adults are have frequent contact days that are quite variable and largely ambulatory. These patterns suggest that there's not a lot of consolidation of services, and these ambulatory services specifically are really concentrated from Monday through Thursday of the week. We see that patient subgroups experience ambulatory contact days differently, and so there's more among younger adults, those who are non-Hispanic white, those who are female, live in urban areas, those with multimorbidity, really importantly, and those with certain care-seeking behaviors. We also see this, really interesting relationship specifically between chronic conditions and contact days, which I think reflects a couple of things. One is actual clinical need. One is this sort of reverse causality, the idea that the more exposure you have to the healthcare system, the more conditions and diagnoses you accrue. And the third idea is that there's a lot more subspecialization and care fragmentation that just sort of contributes to more visits and more tests and more procedures with the more sort of diagnoses you carry. So we've looked at this in subpopulations as well. So this is work led by Emma Chant, who's currently a medical student, finding that for older adults with dementia, contact days consumed 31 days per year. So 10 more days per year on average compared to the average overall average older adult. And you can see the patterns here where, again, it's consumed by a lot of specialist visits, less so PCP visits, treatments, and tests. This is work led by Arjun Gupta, who looked at this within the subset of patients who have a history of cancer. So they're survivors, some have active cancer, but more of them have had cancer in the past. And you again see that there's a large number, a higher number than for the average population, so 28 days a year. And that these are not necessarily taken up by oncology visits. So these are patients who are just potentially more complex overall and are getting more care from a variety of sources, whether the result of iatrogenesis from or the secondary effects of the cancer or the cancer treatment or other reasons. So this is work that characterizes an intuitive, patient-centered, claims-based measure. My hope is that this will be a useful measure to use more broadly. But it's really important to note that contact days requires nuanced interpretation, right? So This is, not a contact day is not inherently good or bad. It's sort of analogous to healthcare spending, where too little spending is bad, too much spending is bad. But if we can achieve the same patient outcomes with less spending or less contact days, we're probably better off. And so that's the important thing to take away as we continue to talk about this. I'll also note that we focus on fee-for-service Medicare, which is because of the data availability for fee-for-service claims. So this may not generalize to Medicare Advantage, which is a growing share of the Medicare population, and now, as of 2023, a slight majority of Medicare beneficiaries. And we're hoping to do some work in the near future to look at MA as well. So I also want to share some qualitative evidence that has expanded my thinking on this. So this came about from, there were some articles that were written in the Washington Post and USA Today, among other places, describing the papers that I just shared with you. And I was fascinated to see a number of comments from readers below these articles that just really painted a picture of how patients, readers, people think about these ideas. And so I'm just going to share 4 quotes that are sort of illustrative of some of these different ideas. So the first is, I used to chuckle at my mom's schedule of visits to the doctor. No more. Now it's me with a calendar filled with medical appointments, not laughing anymore. So just this idea that the sort of physicality of a calendar in front of you filled with medical appointments, I think is really striking, and it's an experience that a lot of people have shared. The second is, it seems that if you visit a specialist of any kind, the specialist deems it necessary for you to schedule return appointments, even if such return appointments are not indicated. Now, this is not unique to specialists, right? All of us have this issue at times of scheduling return visits that might not be necessary, and just generally this idea of, are all of these visits or all of this care really needed? We'll get to that in a moment when we think about solutions, but it's worth noting that this is something that patients and people in the community think about and are sensitive to. The third is, there's a missing quotation there, but if you include the weeks we elders spend on helping our even more elderly parents, or other relatives, that translates to at least 6 weeks of care per year, if not more. I am exhausted from taking my mother to her doctor's appointments. This really resonates as well, this idea of, this individual herself or himself has to manage their healthcare and the caregivers for other people who are doing this, and the way in which these contact days can really compound. The final idea is really interesting too. So this person says, as a senior myself, I think many of seniors have turned medical visits into major lifestyle. More time should be spent on executing major but simple lifestyle changes, diet, exercise, than chasing down one more panacea prescription. So this is a little judgmental, granted, but it's an interesting idea that basically, as people spend a lot of time seeking care for various things, you can sort of lose time or attention on some of the self-care or other approaches to a healthy lifestyle that you would otherwise want to spend time on, right? So it's not really, you're not really just adding time from other things. This can, the time spent seeking care, what we ask patients to do, can really detract from managing your diabetes at home, making healthy dietary choices, things like that. So there's a real trade-off that we need to be cognizant of. And I have to say that, so I'll mention this later, my parents are part of this group very much so, and I see this happen with my father and my mother, and these kinds of quotes really resonate with them and speaks to the experience that they've had. So what are the implications of this? So as we've talked about, for any given contact day or healthcare, there are potential benefits, whether that's clinical, I think that's why we do what we do. So I want to be very clear that obviously healthcare contact days can be very important. There's also social benefits for patients. Even if a contact day doesn't have the most clinical benefit, there are reasons why some folks, including some older adults, want to come in. But there's also these potential burdens, including time, direct costs, opportunity costs. And so I would argue that clinicians, health systems, policymakers, and researchers should and can consider contact days and decisions to try to right-size some of these, our use of contact days. And we can specifically optimize contact days in 3 ways. One is reducing unnecessary care. The second is coordinating care. And the third is shifting care to the home setting. These are all ideas that I think we all think about a lot in our role in the geriatric space. So first I'll highlight, and I'm going to go through these examples in the context of three, or really 3 to 4 main groupings, right? So individual patient care, clinical health system and policy, and I'll get to research as well. So at the individual patient care level, how can you use contact days? So I think about this as, considering contact days as one of many variables when you're sitting down with a patient and choosing a treatment plan. And this should be alongside factors like efficacy and affordability. How much time is it going to take? And one really concrete example that's in the news lately is the new Alzheimer's drugs, where we don't know, the efficacy is questionable, and we see that there are a lot of needs in terms of trying to monitor for adverse effects through MRIs and the treatment of the use of the drug itself. So the conversation should include information about the time that patients are signing up for when they're doing the drug, both directly and indirectly. Another example that comes up a ton that I've experienced with my father as well is in radiation treatment. So radiation is, usually administered on the order of weeks. There are different options that may be higher or lower intensity, and then have associated fewer or more contact days. And those kinds of trade-offs are really important, and the time spent should be part of that conversation. Then at the clinic or health system level, we could track contact days using dashboards that could inform quality improvement. So once again, this is not in isolation. This needs to be considered alongside other things. But if we can get similar other quality outcomes and use less of patients' time, that's a win. And then there's policy. So you can imagine measuring and reporting contact days when evaluating new care delivery and payment models. I'm thinking about models in the primary care setting, accountable care, for example. And you could also consider contact days as a trade-off when developing clinical guidelines. So currently guidelines account for factors like adverse effects and clinical efficacy, but this should be another factor considered. All right. Then the final piece here for uses of contact days is in the research setting. So I'm sure all of you know this very well, that there's been a lot of interest in thinking about healthy days at home or home days as an outcome when evaluating any number of interventions for older adults or more broadly. And one frustration that I've heard some researchers share with me about that measure, and I've seen in the literature, is that there's just not a ton of variation in contact in home days, because fortunately for most older adults, these home days are the vast majority of their days. And so, in fact, MedPAC, the Medicare Payment Advisory Committee, had invested in healthy days at home as a metric, and then ended up abandoning it because of that lack of variation. And there's a line in the report that I found a year ago that basically says, maybe we should consider measuring all days spent. And so this is a little bit of a response to that. So all of that to say that we could measure and examine total contact days and its components as outcomes, again, alongside other meaningful dimensions of high quality care. So one example of how that could play out, so you might be studying a new drug that could influence study participants' contact days through 4 different mechanisms, right? So the drug's administration schedule. So is this an annual infusion? Is this a daily medication that you have to come in for, like radiation or something else? The safety monitoring requirements, so again, MRIs, lab tests, or other things that require someone to come in. There's the clinical efficacy, which in an ideal world, if this intervention works, then it's going to reduce the contact days needed for patients to come in for the underlying disease, right? And then there's the side effects from the medication. So are we having people, does it mean that this medication lead people to come in more because they are experiencing side effects from it? And so taken together, you can imagine how looking at this global measure of contact days can capture each of those elements and really give you a sense of what's going on. Then I want to talk a bit about approaches to optimizing contact days, and I'll take each of these in turn and go into a little bit more depth on them. So the first is the idea of reducing unnecessary care, which I alluded to earlier. And here what I mean is essentially low-value care, which I think will be familiar to many of you. This is the idea of services that have little to no clinical benefit, yet have potential for harm. Another way of putting it is things we do for no reason. So you can see how low-value care is a very attractive, modifiable contributor to contact days. This low-value care has a huge impact on older adults in particular through direct costs, patient harms, as well as opportunity costs. And by some estimates, it costs the U.S. about up to $101 billion per year on wasteful spending. The image you see here, I know is very small. This is just to give you a sense of the opportunity. So this is a study where we looked at US health systems across the country. And we looked at 40 different low-value care measures, ranging from prostate-specific antigen testing in older men to, this is all in Medicare as well, I should say, to, let's say, head CT for sudden hearing loss, among those for whom it would not be high value. And each dot here is a health system. The x-axis goes up to 1, but it's on a log curve, so you can see that about the 0.5, I'll just highlight it here, is around here. And what you can see is it's just marked variation for most of these measures or services in practice at a health system level. So there's some who are doing really well on this and avoiding low-value care, and others who are not. We also know that low-value care can cascade. So this idea of cascades is something that I am really interested in. It's a pattern we've all seen, whether as clinicians or as patients, which is a cascade that can be triggered by an abnormal finding or of some sort and can lead to additional calls, visits, tests, and treatments, each one a seemingly logical, even inevitable conclusion from the step before, but often full of sound and fury and signifying nothing. So these cascades can cause more harm than good, and especially when they come from low-value testing or any kind of low-value care, or from an incidental finding, something that you were not intentionally looking for. And they're often driven by the desire to avoid even the slightest risk of missing a potentially life-threatening condition. So we have good evidence, as I mentioned earlier, from our work and others on low-value care, sort of the initial event. And what some of the work that my team's been doing is thinking about what happens next. What are the cascading events and the impact of those cascades that can follow from low-value care? So what you see in this figure is sort of a depiction of these cascades, and they come from these unnecessary services as well as unexpected results, which are quite common. So just to put one number to it, when we look at imaging tests, about 1 in 4 have some sort of incidental finding, and those numbers are likely to rise because imaging studies have become more sensitive. So in doing this work, our first foray into it was looking at the poster child of low-value care, which is pre-op testing before cataract surgery. So I think you all know very well that cataract surgery is incredibly common in older adults. It's also an incredibly low-risk procedure. It takes about 10 minutes for the ophthalmologist to perform. And there's robust evidence that's codified in multiple guidelines that routine testing before cataract surgery does not help. It does not improve pre-op outcomes or operative outcomes or have any other clear benefit. And it's especially true for patients without heart disease. Yet it's still really common to do these tests. The prevailing estimate before we did the study was about 1 in 4 older adults getting cataract surgery got this pre-op testing, including EKG. So we wanted to measure the cascades that followed these events. So we looked at Medicare beneficiaries who are older adults with no heart disease and had cataract surgery. We compared pre-op EKG recipients with non-recipients, adjusting for a number of potential confounders. And we looked at cascade tests, treatments, visits, hospitalizations, and new diagnoses in the 90 days following their visits, or their surgery, I should say, or a matched date in the comparison group. And this is some details that I show here about how we established these different periods of observation. We found that in this study, using a conservative definition of cataract surgery and pre-op testing, about 11% of recipients received a pre-op EKG. And the adults who received these were older on average. They were more likely to be slightly sicker, meaning they had a slightly higher Alexander condition count. They were also more likely to live in urban areas, and they lived in areas that had greater density of cardiologists. So speaking to supply-induced demand. So all of these variables that were predictive of getting more pre-op EKGs is broadly consistent with broader literature on low-value testing. We found that 16% of these pre-op EKG recipients experienced a potential cascade event. And what we mean here is that they had something in the subsequent 90 days that could have followed from an abnormal result. In claims data, we cannot look at causality in that way, but this is giving you a sense of what may have happened after. So this included people or visits to a cardiac specialist following that EKG, or various services related to ischemic heart disease, structural heart disease, arrhythmias, or some combination. For every 100 EKG recipients, there were 5 to 11 additional cascade events in the following 90 days, meaning when we difference out the experience of people who didn't get the EKGs and acknowledging that these cascade services are just things that people can commonly experience, the additional potential impact of the EKG was about 5 to 11 additional cascade events. And you can see that in this sort of time on the x-axis, that a lot of these services were happening in the initial days to weeks after that first surgery, or the pre-op EKG itself. And so the dark blue is any cascade event, the lighter blue is any test, and the light white is any cardiac specialist visit. And it's really sort of concentrated in the early days, which lends some credibility to this estimate. We also found that specifically that pre-op EKG recipients had extra downstream services, including more tests and treatments. So more electrocardiograms, stress tests, echocardiograms, event and Holter monitors, and catheterizations. They had, and you can see just on the right-hand side, all of these adjusted attributable estimates. You can see they had more hospitalizations, more new diagnoses, including often a diagnosis of abnormal EKG, which we looked for specifically. And then when you estimate, and these are all event rates per 100 bennies, but when we look at spending, we estimated it per beneficiary who got the pre-op EKG. And we found that there was an additional $565 in spending per beneficiary associated with the pre-op EKG. So when you think about the cost of the EKG itself, which is roughly $50, the cost of the cascade was 10 times that. And when we estimate this, or we extrapolate across the country, and we think about all patients who are getting these cataract surgeries in Medicare, we estimate about $35 million spent on cascades from these EKGs alone, not counting all the other aspects of spending here. We also found that older and sicker patients were more likely to experience potential cascades. So those who are 85 plus had 1.54 higher odds of having some kind of a potential cascade. Those with higher Alex-Salter counts, those for whom the cardiac specialist ordered the EKG as opposed to a PCP, and those, once again, who are in areas where there were more cardiologists who were available to do that downstream testing or treatment. We've also looked at this in the context of annual wellness visits. So as you all know, I know Jeff Linder is really interested in this area as well. Annual checkups with routine testing is common but of low value for healthy adults. And in 2011, Medicare introduced the annual wellness visit, the first time Medicare reimbursed at no cost to beneficiaries a visit of this type. And we thought this may prompt routine testing and in turn cascades that follow from that initial test. So we looked at the use of routine tests during annual wellness visits and whether there were cascades that followed there. We focused on 3 routine tests and found that 19% of annual wellness visit recipients got any of these. So about 7% got a EKG, about 10% got urinalyses, and about 9% got thyroid screening testing. And these are among patients where there was no, we're very careful to exclude folks who had any appropriate indication for this testing, and to also exclude tests that were done for appropriate indications. We found that these EKGs led to an additional 6 cascade events per 100 patients. The urine testing led to an additional 5 cascade events per 100 patients. And the thyroid testing did not lead to additional testing per events per 100 patients. But we think that may have to do with our sort of short period of ascertainment, which was only a couple of months, and would expect to see this if we had also been able to look at Part D data for this study. So specifically new prescriptions for levothyroxine, for example. So likely an underestimate. So putting all of this together, there's other studies that we've done in this area that I will not bring in today, but putting it all together, it seems that cascades seem to be quite common. They follow from unnecessary tests or unexpected results, and they're driven by similar factors that drive low-value care in the first place, meaning practice norms, the culture of medicine, individual anxiety or intolerance of ambiguity. So we did a national survey of American College of Physicians members where they report their experience with cascades, and that was a big theme. We also see that fear of malpractice lawsuits plays a big role. as does perceived patient complexity and supply-induced demand. Both of those we find from the pre-op EKG study, in that patients who appear sicker or patients in areas with more cardiologists had more of these services. We also know from this work that physicians often experience cascades. It's basically almost everybody in this study, in this survey, reported that they've seen them, and they're really common. And they're more often cascades that lead to nothing than cascades that have an important and intervenable outcome. So I know this is also a very detailed slide. What this is showing is sort of an ecology of cascades. So the darkest blue references cascade elements that doctors experience at least weekly, all the way down to the lightest white is never. And you can see that phone calls with patients are really common, and even more higher acuity cascade elements like hospitalizations. The majority of doctors who responded experienced that at least several times a year, or more than never, I should say. And that you can also note here that cascades that have no clinically important or intervenable outcome are more common than ones where it was important in the end. And this is specifically from incidental findings, I should be clear. Okay, we've also learned from this work that tests vary in their cascade potential. It is not the case that any test is equally likely to have a cascade. And for any given test, the minority of patients who receive the test are going to have an abnormal finding and therefore a cascade. But those costs are significant and other harms are significant, and they can accrue, as we found out with the EKG example. So putting this together, knowing that cascades are common, they come at significant cost to patients, physicians, and society, what can we do about them? The first approach is to avoid that initial test when possible. So thinking about ways to avoid low-value care through choosing wisely, which is the national, now international campaign to point out services that are of low value. There's quality improvement initiatives that I point out here, a study done by John Maffei and colleagues at UCLA, where they focus specifically on pre-op testing for cataract surgery and use a PDSA cycle and communication with ophthalmologists and others in the health system to reduce this unnecessary pre-op testing. And there's also a number of payment and policy changes. So at a payer level, it's not popular, but prior authorization is one way of addressing this, as are coverage decisions. And then physicians can think about, and health systems can use clinical decision support. Policymakers can, one idea is to incorporate some of these measures into performance metrics for accountable care organizations and others. So there are a number of ways to avoid that low value care in the first place, which may then turn into more services. And in support of this, we did a study looking at choosing wisely, where we codified the different elements or the different sort of dimensions of these services. And one thing I'll note is that even though a small and diminishing share of low-value services have high direct costs, so on the right-hand side, you can see the dark blue is a service that costs more than $2,000. The lightest is less than $200. We know that, we found that a number of these services have direct harm potentials, and even more of them have high cascade potential, meaning the service itself may seem benign, like a routine blood count during a physical for a healthy person, but that can cascade into more and more services that can then cause harm. And so about 62% of the services we looked at, we found to have high cascade potential. And these could be services that we target when trying to reduce low-value care. And you can imagine how that would also improve on contact days. So the second idea, in addition to avoiding the initial test, is to mitigate the downstream effects of these tests through point of care and evidence-based guidelines and peer support. And that's harder to do, right? So once you see an abnormal finding, it's really hard to unsee it, and therefore to not do the follow-up testing or treatments. It's often really hard because, a radiology report may say something ambiguous or say, an MRI would further characterize these findings. And that the finding itself has no clinical correlation or something else, but it's very hard to sort of to take on that risk as an individual clinician. So to mitigate cascades, we really need to give patients and doctors the information and the cover to make those harder decisions to do less. And this could mean, as I mentioned, the point of care or evidence-based guidance. It could mean radiology reports having that guidance baked in so that some of that risk is shared with the radiologist. And it could also mean peer support in making those decisions. So I'll get back to this idea of, what can we do at these different levels to reduce unnecessary care, much done at a patient level. So when you're sitting with a patient, you can think about some of these ideas in the context of those conversations. So you can use, for example, shared decision-making or clinical judgment to forego marginally beneficial services. So one example might be, and this, we've all done this, I have done this, where there's a slightly abnormal result in maybe an unnecessary test or maybe not, but a result is slightly abnormal, and we want to do another test, like have someone come in a week later to follow it up and get another result, which hopefully that one's normal, and then we assume that it's always normal, right? Which is a little bit irrational. But that's something that you could imagine with a conversation with the patient, with some clinical judgment, you could forego. At a clinic or health system level, you can imagine changing health system workflows to reduce low-value service use. And for example, the one I gave about from Dr. Matthews' group is eliminating low-value pre-op testing before cataract surgery and the cascades that can follow from that. At a policy level, I mentioned earlier as well, you could consider using low-value care or other types of measures as a performance metric for ACOs. The next idea is to coordinate care, so meaning consolidating care into fewer days. And so for this, there's a lot we can talk about. I'm going to focus on one really interesting study that some of you may know by Hal Luft and colleagues from the Palo Alto Medical Foundation. So in this study, the authors grouped primary care doctors by their visit style and specifically how many conditions they addressed during acute care visits. So on one end of the spectrum, there were max packing or max packers, and the other end were focused visit styles, depending on how much they discussed. I'm sure all of you are thinking about your own visits and what you might be. I know I'm definitely a max packer, for better or worse. So what they found when they looked at patient outcomes from each group of PCPs, max packers had 3% lower resource use for their patients, so downstream, better clinical quality, and similar patient experience scores, with the exception, not surprisingly, of wait times. And importantly, these doctors spent more time in the electronic health record. So there were costs to the patient, to the doctors, of spending that extra time, but there are also real benefits, essentially, in consolidating more of what patients needed into a given visit. And you can sort of think about, it sort of makes sense, right? Your patient comes in to see you in clinic. I think geriatrics is particularly good at being being max packers and looking at the full expanse of issues. But there really does seem to be a benefit in terms of health outcomes, in terms of resource use. And here you can see specifically downstream services with specialists and others that comes from doing more in a given visit. And if we sort of operationalize this idea, we also have to be very cognizant of the toll that takes on doctors and burnout because of that extra time and the extra work that doctors are doing in those moments. So it's a trade-off, but it's important to consider. So thinking about coordinating care across these three elements, so at the individual patient care level, you can imagine, like I said, maximizing care in a given office visit. And one example, but there are so many, is to offer, if somebody comes in for knee pain, you notice that they're due for their B12 injection, that they're going to come in for a nurse visit a couple days later. You give them that injection at that visit. At a clinic or health system level, you can imagine using EHR clinical decision support to prompt any member of a patient's care team to provide a service when patients present for care. One concrete example that I would mention is that in my Epic view, I can see any routine screening needs that patients are due for on the bottom left of my screen. So if I'm seeing the patient of a colleague in my primary care practice and they're due for their mammogram or they're due for their fit test, I can take a look there and order it for them and prevent them from having to come in for another visit for those things. And then there's also the idea of same-day scheduling across service categories for a specific diagnosis. So we often, and I will say our health system is very much one of those systems, will ask patients to come in different times for different specialists who are all managing the same condition. And you can imagine for certain conditions that lend themselves to more collaboration among specialists, for example, cancer or dementia, having these co-located visits and coordinating this. This is something that places like Mayo Clinic do really well, and others like us do not do well, but there's really an opportunity there. At a policy level, there are policy, and for example, payment models that incentivize co-locating and coordinating services through, let's say, bundled payments. So CMS has a bundled payment for care improvement initiative that focuses on coordinating care for patients who are getting knee and hip replacements. And then you can also imagine, or there are primary care, Medicare models in primary care that incentivize multimodal and efficient care over care volume. So one very concrete example of that is if doctors in these models are getting prospective payments per member per month for their patients, rather than relying on fee-for-service revenue, they're not going to schedule that extra doctor's appointment to discuss test results, which, by the way, still happens to my parents all the time. But rather, they're going to pick up the phone and call the patient to explain the test results and then prevent that visit because they are not trying to get the revenue from that extra visit. All right. The final idea is shifting care to the home setting. So here, this is I'm familiar to many of you, of course, that COVID compelled the expansion of virtual care very rapidly in 2020. And this was accompanied by policy changes and adaptation by payers, regulators, vendors, and health systems to really make this happen. This is an image showing what happened in March 2020, that specific week where we had this huge drop in in-person and total visits and a rise in telemedicine. I will skip ahead to the current state, which is that virtual visits are less common, but still here to stay. We're still seeing a lot of virtual visit use, including in the Medicare population. There's some data that we're about to publish, but as of now, as of 2021, about 10% of visits were virtual. And Medicare has so far extended the public health emergency extensions to have broad coverage of this telehealth. So as of now, it's through December 2024, but they're likely to go further. And there's some details that we're still discussing about how to actually do this. So for example, continued reimbursement for audio visits outside of behavioral health is sort of on the chopping block. And we know that there's disparities in who gets phone versus video visits. This image shows one example in our health system where we found that patients who were Spanish speaking and had Medicaid, for example, had lower use of, had more phone than video. But in fact, it's a little bit more complicated than that, in that we find also that Medicare patients often choose phone when given the option. So all of that to say that virtual care is still commonly used. We should be flexible about the ways we use it and offer it, including phone and video options. And this is one way in which we can imagine shifting care to the home to the benefit of older adults. So what's the extent of this opportunity? This is a really cool study that Emma Chant, that I mentioned earlier, who I mentioned earlier, is leading, where she estimated missed opportunities to switch care to the home setting. So using the same data set we described for contact days, she identified services amenable to home health or telemedicine based on a taxonomy of healthcare services that can be provided at home. That includes things like behavioral health, lab tests, and physical therapy. And she found that 27% of ambulatory days were potential missed opportunities to shift care to the home setting. So what you see in the image on the top here is actual ambulatory contact days. So basically, the y-axis shows beneficiaries or people waited, and the x-axis shows each individual's number of contact days, and the mean is 22 in that context. Then when you sort of manually shift all the potential home days, and specifically for days where there was only a service that could have been done at home, you find that see this dramatic shift to the left, and you see that the average number of contact days, if we were to take those opportunities, would be down to 16. The main contributors to these missed opportunities were physical therapy, rehab, and speech, as well as lab tests, behavioral health visits, podiatry, and imaging. So thinking more about shifting care to the home, so at an individual patient level, you could imagine managing conditions remotely when possible. So one example that comes up in my clinic a lot is I'm prescribing a home blood pressure cuff and scheduling a virtual visit, or even communicating through the patient gateway to follow up on hypertension. At a clinic or health system, you can offer or provide some of these technologies and workflows to allow for the virtual visits as well as remote patient monitoring. And you can offer home services like hospital at home, visiting nurse, and home visits to make that shift. At a policy level, this includes reimbursing for audio and video virtual visits and remote patient monitoring. All right, so reached the end. So I hope I've convinced you that getting to the doctor's office or hospital is not trivial for anybody, and especially for older adults and their care partners. And yet we ask older adults to come in often, on average 21 days a year, and for many, many adults, it's more than that. Given the trade-offs of contact days, we can optimize how we use these days by reducing unnecessary care, coordinating care, and shifting care to the home. So I want to thank Nick, who's my RA and helped with these slides, as well as my many collaborators and the inspiration for this work, which is my patients and my parents, as well as the NIA for their support. And I'd love to take any questions.
It looks like there's a couple of questions on the chat. We can just go through them. So yeah.
I can see them. I'm happy to.
Okay, cool.
Do healthcare visits include PT or OT only doctors? Yeah. I think that would probably have been referring to the contact days. And the way that they're coded in Medicare, the office visits include mental health as well as physicians and other clinicians, and other sort of NPs, PAs, et cetera. But PT and OT is coded separately as a treatment. And then the question about labs at home. So this is not my area of expertise, but I understand that there are ways to do mobile labs, and there are some at-home testing. There's also at-home testing that can be done for certain, so like, at-home glucose monitoring, for example, or mobile services or home VNAs, which have their own trade-offs, but is an option.
Great. This is Mike. Sorry, I with our permissions, I don't have access to my video, but I know we're at time. Thank you so much for an incredible presentation. You packed in so much. So if we have any other follow-up questions, I hope we can send them your way. And again, thank you and happy Friday.
Thank you. Great to see you all.